So what investigations can be done to rule out the causes one by one? Like in common general examination, we do day-to-day altered sensorium, we do the CSF study, lumbar puncture, to rule out any CSF infection, meningitis, meningisma, cerebellitis, sometimes cerebellar abscess, and also rule out GBS, lymphocytosis, and EG to rule out other causes of postictal phenomena, pseudoataxia. CT-MRI, which can lead to some syndromes, agenesis of cerebellar worms, likewise in Zubert syndrome, tumor, trauma, stroke, edema, etc. Nerve conduction velocity tells about the GBS and episodic ataxia. And urine for vinyl mandelic acid and this another metabolite suggestive of neuroblastoma, paraneoplastic syndrome, urine and drugs for toxicity, and drugs and toxins level. So how to approach for ataxia? First of all, by history, then examination, then investigations, then other. History, always take the history of the fever, infections, drugs, toxins, medications, trauma, family history of migraine, seizures, etc. And what is the mode of the presentation of ataxia? Is it acute, chronic, gradual, episodic, like this? And then you have to examine the skin, ears, meningeal signs of raised ICT, uh, for papilledema, fundus examination, cerebellar signs, peripheral neuropathy, other signs you have to see lymphadenopathy, splenomegaly, Romberg sign, this opsoclonus, myoclonus. They are suggestive of the typical etiology. And you have to also do the investigations like drugs and toxins level, CT, MRI scans to see the like molar tooth appearance, ADAM, we can see in ADAM, neurodegenerative disorders, conduction velocity study, EMG studies, metabolite screening in the urine and the plasma, like vinyl mandelic acid or homovalenic acid, blood screening, metabolic screening, blood pH, acid-base balance, etc. And special studies also urinary catecholamines, electronystagmograph, immune-mediated causes, MIBG scans, and other body scans. This is how, by step, by history, examination, special test, and routine investigation, you can reach up to the pinpoint. You can pinpoint the cause of ataxia. So coming to the causes one by one, infective causes, acute cerebellar ataxia is ataxia seen in the children 1 to 3 years of age. It is mostly 99% post-viral, post-cocci, chickenpox, varicella or eco infection 2 or 3 weeks after. It is due to autoimmune response to these viruses, and they present, and this autoimmune response to these viral agents, this affect the cerebellum. And presenting feature may be like vomiting, fever, and then follows the ataxia. So fever is a clue. Fever gives you clue that it can be infective. In no other diseases, no other cause of ataxia, fever is mostly present. Horizontal nystagmus is present in 50% of the cases, and dysarthria may be present in the older children. And CSF is mostly normal because there is basically no meningitis, no meningeal involvement. It is the only involved part of the cerebellum is due to autoimmune process. It is not inflammatory. It is basically autoimmune process due to any of the viral infection. This acute cerebellar ataxia improves after a few weeks, but may take at least 2 or 3 months. It may take sometimes. The prognosis is excellent, but sometimes residue may remain in form of behavioral problem or ataxia sometimes as a long-term sequelae. Acute cerebellitis after this is a rare form, a severe form of ataxia. Symptoms are severe and long-term sequelae. Causes may be again viruses, mycoplasma, Epstein Barr virus, mumps, influenza. Sometimes acute infection of the labyrinth and is associated with the middle ear infection. It presents as vertigo, ataxia, and vomiting. So acute cerebellar ataxia, acute cerebellitis, cerebellar abscess, labyrinthitis may be the infective causes of acute cerebellar ataxia. Now the tumors, talking about the tumors of the cerebellum and the frontal lobe Also, the frontal lobe is involved in ataxia. Cerebellar tumors, disruption of the cerebellar function, raised ICT from the compression. What do? They increase the cerebellar raised intracranial pressure by compression of the fourth ventricle. Frontal lobe tumors, what do? They disrupt the association between the frontal lobe and cerebellum. So there are corticocerebellar fibers which are disrupted due to frontal lobe tumors, and so there is lack of coordination of the movements presenting as ataxia. Neuroblastoma. Neuroblastoma are the tumors in the abdomen or many other places where they are associated with paraneoplastic encephalopathy characterized by ataxia, myoclonic jerks, opsoclonus, etc. So tumors of the brain, tumors of the frontal lobe, cerebellum, and paraneoplastic tumors. What is Miller-Fisher syndrome? It is a form of GBS, rare part of GBS. It is characterized by triad of areflexia, ataxia, and external ophthalmoplegia. It's a rare phenomena, but it is a viral disease, as we all know. Behind every GBS, mostly there is a viral disease. Viral infection precedes the neurological symptom 5 to 10 days in many of the cases. Recovery happens in 2 to 4 weeks after the symptoms and complete within 6 months. So Miller-Fisher variant of the GBS can present as ataxia. So how do you manage each case one by one? Post-infective cases like chickenpox, mumps, spontaneous recovery, we do only symptomatic management. Neuroblastoma tumors, we do give IV immunoglobulin 1 to 2 gram per kg per day every month. Miller-Fisher type of GPS, IV immunoglobulin 2 grams per kg per day for over 2 to 5 days. Toxins, you have to give the antidotes and to remove the toxin. Vertebrocerebellar dissection due to trauma, so you have to give antiplatelet therapy, anticoagulation. ADAM, again IV immunoglobulin, plasmapheresis. Recovery slow, multiple relapses raise the possibility of multiple sclerosis. So prognosis is not very good in ADAM. So once we rule out the active infection, then the trial of immunosuppression is normally warranted. You don't have to start from the immunosuppression right from the beginning. After the acute infection, because sometimes the infection may be flared up when you start immunosuppression IVIG like in the beginning, or steroids, 20 to 30 mg per kg methylprednisolone for 3 to 5 days. If no improvement, you give IVIG or plasmapheresis as second line therapy. If patient who does not show resolution, give this rituximab 375 milligram per meter square weekly for 4 weeks. Okay, monoclonal antibodies, rituximab. It has been reported to show benefit, though the things are not proven yet. So after this acute asthma, acute ataxia, we have covered most of the things about acute ataxia. Coming to episodic ataxia. Episodic ataxia are mostly inherited. Problems are related to the chromosomes, various genes, various channels, and there is wide variety of the patients of the acute episodic asthma, ataxia. Sometimes there is ataxia, sometimes the child is normal. Chromosome problem at EA1 to many multiple E8, episodic ataxia 8 has been documented. Various problems in the chromosomes and various genes. Age of the onset may vary from the early childhood to the later adulthood, and duration also. Sometimes frequency is very far. Sometimes they happen very frequently. Sometimes days or minutes or even months, once in a day, once in a few days or once in a few months. So features are also variable. This is how you approach a case of ataxia. So you see for the clinical feature, age of the onset, complaints, symptoms, progression, family history, then you do the imaging, CT, MRI, etc. Then other imaging, you see there is cerebral atrophy, cerebellar tumor, hypoplasia of the vermis, molar tooth appearance, or white matter, gray matter degeneration. Then you see it is acute episodic asthma, acute episodic ataxia, progressive ataxia with spinocerebellar, or progressive ataxia, include disorder that have complex neurological feature and ataxia with myoclonic episodes. So you go with the rare investigation and you can diagnose many things. Episodic ataxia may be seen in the maple syrup urine, heart nerve disease, late onset urea cycle defect, dominant this autosomal dominant ataxia seen in the spinocerebellar ataxia, Friedreich's, vitamin A beta lipoproteinemia. We'll take one by one the important ones, rest we'll skip. So what are the hereditary type of the ataxia which are seen in the families? The presence of these ataxia risk factor generally suggests genetic or metabolic, like duration of symptoms more than 2 weeks, consanguinity because autosomal recessive disorders appear due to more frequently due to consanguineous marriages, of your first degree relative with the similar symptoms, presenting feature of the gait, rashes, ichthyosis, and abnormal examination of the motor system like the DTR, clonus, so there are various groups of the heredity like enzyme defect, degenerative, spastic. Non-progressive cerebellar ataxia or congenital anomalies. Early feature in the first few years of life include how they present the children, the hypotonia, developmental delay, feeding difficulties, oculomotor, oromotor apraxia, delay secondary to articulation difficulty, speech delay, ataxia, cognitive difficulty at a later age. So congenital anomalies of the posterior fossa, Dandy-Walker, Chiari malformation, and Keflozil are prominently associated with ataxia. Agenesis of vermis in infancy with hypotonia and decreased DTR. Delayed milestones and truncal ataxia are typical. So MRI is the investigation of choice for congenital anomalies. You have to see for the vermis, cerebellum, what is happening to the adjoint structures. Now, what is the word about the Zubert syndrome? These are related disorders, autosomal recessive disorder. It is characterized by the developmental delay, hypotonia, abnormal eye movements, abnormal respiration, distinctive malformation of the cerebellum brainstem that manifest as molar tooth appearance in the axial MRI, which is classically suggestive of molar tooth appearance is suggestive of Zubert syndrome. Neurological representation of the Zubert syndrome is hypotonia, including ataxia, developmental delay, abnormal eye movements, and breathing problems. Multi-organ involvement of the kidney, liver, retina is present many times. Then genetic mutations for the various proteins is present in Zubert syndrome. These include nephronophthisis, senior Loken syndrome, Bardet-Biedl syndrome, and Meckel syndrome. So this is a scan where you can see molar tooth appearance. Now coming to hereditary ataxia, this is Friedreich ataxia. It is autosomal recessive inherited disorder involving the spinocerebellar tract. Here the tracts, dorsal column tracts, pyramidal tracts, spinocerebellar tracts are involved due to mutation in the various mutation for the GAA trinucleotide repeat. So there is a mutation. It's autosomal recessive. Consanguineous marriages increase the risk of Friedreich's ataxia. This mutation leads to formation of abnormal protein called as frataxin, which causes oxidative injury associated with iron deposition. Variable age of onset is noted. Key neurological feature is ataxia, dysarthria, nystagmus, uncoordinated movements, decreased knee jerk, ankle jerk, Babinski sign, impaired position and vibration. Various systems like cardiac, skeletal muscles may be involved. Cardiac system may present as hypertrophic cardiomyopathy associated with aortic stenosis leading to the CHF. Skeletal muscle may present as abnormal, may present as pes cavus, scoliosis, hammer tooth, abnormal GTT, diabetes mellitus. So it is a multi-system involvement in Friedreich ataxia. DK may be a late presentation. When you do the ECG are the part of cardiac assessment. Nerve conduction in EMG will confirm the involvement of muscles and the nerves. No specific treatment other than the symptomatic and supportive, but sometimes coenzyme Q and some antioxidants like the metoquinone, IDPinone, they are found to be effective. Some metabolic causes like deficiency disorders, like fat-soluble vitamin deficiency, especially seen in A-beta lipoproteinemia. It is a metabolic disorder, autosomal recessive, caused by mutation in the microsomal triglyceride transfer protein, MTP protein. Okay, it is seen. Now, how do the children present? They present as chronic diarrhea, steatorrhea, and failure to thrive. When you see their blood smear, there are acanthocytes. Acanthocyte means the RBCs with the sharp margins, and acanthocytes, this needle type features in the outer edge of the RBCs. Decreased serum cholesterol, triglyceride, and absent beta lipoprotein. When you estimate the level of beta lipoproteins, they are absent. So posterior column signs, neurological signs present in the late childhood. They present as ataxia, retinitis pigmentosa, neuritis, and abnormality in the position and vibration sense, intellectual disability, muscle weakness, etc. So how do you treat? By a high dose of fat-soluble vitamins. You give vitamin A, which is beneficial for the posterior column features. Also give vitamin A, D, K. Must be supplemented. Other important metabolic disorders are arginosuccinic aciduria, heart nerve disease, which is treated by the niacin. Some degenerative disorder, ataxia telangiectasia is also important cause. It's a neurocutaneous syndrome, autosomal recessive again, presents at the age of 2 years, and there is a progressive loss of this coordination, movements, and ambulation by adolescents. There is problem in the mutation in the ATM gene on the chromosome number 11, short arm 22. 11q22, ATM is involved in repair and cell cycle control. So what happens? Oculomotor apraxia of the horizontal gaze is defined as difficulty in the shifting gaze from one object to another. Person is not able to shift the gaze from one object to another and overshooting the target with lateral movement of the head. What happens in ataxia telangiectasia? It also may present as chorea. So where are the telangiectasia seen? They are basically capillary malformations seen in the childhood, and mostly they are found in the bulbar conjunctiva, bridge of the nose, ear, and extremities. What do you find in the blood investigation serology? You find decreased secretory immunoglobulin A, which leads to frequent sinopulmonary infections. Sometimes you suspect ataxia telangiectasia by frequent sinopulmonary, repeated sinusitis, repeated LRTIs, etc. And you go for the serum IgA levels, they are very, very less. So there is also increased risk of lymphoreticular malignancies, and child mostly die from these complications of lymphoreticular malignancy or brain tumors dissemination. Molecular genetic testing is performed for mutations. And what else you see? You will see increased serum alpha protein levels in 90 to 95% of the patient. What are the other form of ataxia? Spinocerebellar ataxia. There may be infantile onset spinocerebellar ataxia, is autosomal recessive neurodegenerative condition characterized by developmental regression after first year, followed by ataxia, hypotonia, loss of DTR, athetosis. By the age of 7 years, ophthalmoplegia and deafness also evident. Mutation is again in the C10 to F2 genes from the base of this disorder lead to mitochondrial DNA depletion, particularly in the nervous system. Both homozygous and heterozygous mutations are described. So child becomes loss of ambulation as soon as the child gets older, and later on also problem with the vision and auditory disability also happens. Myoclonic jerks or the focal clonic jerks that progress to epilepsia partialis followed by the status epilepticus may be a feature of spinocerebellar ataxia. Another is the progressively dominated inherited ataxia. These are dominantly inherited spinocerebellar ataxia that are described, and various types. Mostly they present multiple groups present as ataxia, fasciculation, lid retraction, and reduced ocular saccadic velocity. So at the end, I should summarize the topic. in brief sentences. So, what is ataxia? It is inability to maintain the normal posture and smoothness of the movements. Etiology is diverse, multiple causes, mostly para-infectious, metabolic, vascular, immune-mediated, post-inflammatory, traumatic, or paraneoplastic. Chronic pediatric ataxia may be genetic, structural, or metabolic. Acute may be post-infective. Episodic are rare autosomal dominant, sometimes acute, chronic, and episodic. Zubert syndrome is a rare disorder. It is diagnosed by the neuroimaging MRI molar-tooth sign. Friedreich ataxia is hereditary ataxia, in which there is ataxia, dysarthria, nystagmus, and decreased DTR, Babinski, and problem with the posterior column sensation, and of course, cardiac and skeletal muscle involvement. A beta lipoproteinemia presents as chronic diarrhea, acanthocytosis, decreased cholesterol levels, and signs of vitamin E deficiency. Ataxia telangiectasia is a neurocutaneous syndrome due to ATM gene mutation. Infantile onset spinocerebellar ataxia is autosomal recessive neurodegenerative disorder, and spinocerebellar ataxia are also varied. There is very diverse presentation. Thank you.